Heart failure is a condition, okay? Similar to SIADH and diabetes insipidus, do they occur on their own? No, same thing with heart failure. Heart failure is a state, it's a condition. You don't just wake up one day and then you got heart failure with no underlying cause. Are we clear? Okay, so there are tons of conditions that can lead to this condition, to this state. It has no cure. Well, I should say there is. You need a heart transplant, basically. Okay, so if you want to get rid of heart failure, you need a new heart. So several things lead to this condition. The definition of heart failure is an overall inability of the heart to pump effectively. See, the heart is unable to pump enough blood to meet the patient's the body's metabolic demands or needs. Okay, that is a condition. Again, you don't wake up one day with just heart failure. So there are certain conditions, underlying diseases that lead to this condition, to this state. All right? Do you understand?
Yes.
Because it's a chronic condition, there are two forms. Again, heart failure is a chronic condition, meaning you can live relatively normal lives at home, just like everybody else, with medications and diet compliance. However, there are acute conditions, meaning you can be hospitalized for an acute exacerbation, meaning when the patient's body decompensates, can no longer compensate for the inefficient pumping of their heart, then they will have symptoms and therefore will have to be admitted to the hospital. Are we clear? Now, we never admit for a chronic condition, do we? Let's say I have diabetes and I have cholesterol. Do I have to stay in the hospital for the rest of my life? No, I will only go to the hospital if I have acute symptoms. So let's say for my diabetes, let's say I have any of the three acute complications, hypoglycemia, diabetic ketoacidosis, or HHS. Those are acute complications, right? So I need to go to the hospital. Or if I have, let's say, high cholesterol, if that leads to plaque in my coronary arteries and then I have a heart attack, then I go to the hospital. Are we clear?
Yeah.
Right. So we never hospitalize for chronic conditions. We hospitalize heart failure patients if they have an acute decompensated state, or otherwise more commonly known as acute exacerbation of heart failure. Okay. So therefore, since we have two sets of manifestations, we have acute and chronic, we only admit for which conditions? The acute problems. So the patient will have to be admitted if they have acute manifestations. So therefore, do we need to know to distinguish between acute and chronic symptoms? Okay. You have your textbooks, right?
Yeah.
Okay, so just follow along with me. I'm on 794. The Apple TV is not cooperating. Let's look at the causes now. I'm on page 794 under the paragraph that says HF is more prevalent among African Americans. Are you with me? Okay, I'm on that paragraph. So this paragraph lists the risk factors. So we have modifiable and non-modifiable risk factors for heart failure. Where does ethnicity fall under? Modifiable or non-modifiable? Okay, very good. What about age? What about cigarette smoking? Obesity? Poorly managed diabetes? Modifiable, yeah. Right, so if you manage it well, then that's modifiable. Metabolic syndrome. Okay, let me refresh your memory. So if you forgot what metabolic syndrome is, there are 4 characteristics of metabolic syndrome. You have diabetes, high blood pressure, abdominal obesity, and what did I say first? Diabetes, hypertension, abdominal obesity, and then high cholesterol. If you have these 4, you have metabolic syndrome. That's modifiable, right? Because can you manage diabetes? Can you manage hypertension? Can you lose weight? Can you control your lipid levels? Yes, that's modifiable. All right, so these are risk factors for heart failure. And the root cause of most heart failure is a heart attack. And heart attacks are caused by atherosclerosis. What is atherosclerosis again? Caused by a plaque deposit. So pretty much you have narrowing of your arteries, correct? Okay. I still can't get the Apple TV. This is 512, right? Okay, but are you with me? Okay, so let's scroll down because the other paragraphs here will just discuss further risk factors. Okay, and then you can read that on your own. So next paragraph talks about cardiomyopathy. We have valvular heart disease. We will discuss valvular heart disease under module 8. So we will return to this chapter under module 8 later. Okay. So heart failure, there are 3 ways you can have heart failure. So let's discuss the 3 elements of perfusion. What is perfusion? Okay, so that is the delivery of oxygen to the tissues, correct? Okay. So there are 3 elements in perfusion, meaning without these 3 elements, you cannot deliver. I'm on pathophysiology now. 794. Okay, so for perfusion or delivery of oxygen to the tissues to be possible, you need 3 elements to be working perfectly. 1, you need a pump. The pump is referring to which organ? The heart. Next element is blood volume. You need enough blood volume in order to circulate blood throughout the body. How much blood does any living person at any given time have? About 5 liters, right? Average 5 liters of blood. Next is blood vessels. Which blood vessels have muscles? Arteries. So those arteries must be able to constrict and dilate according to the patient's needs. Whenever we want to decrease or increase blood pressure, the arteries must be able to constrict and dilate respectively in order to adjust to the needs of the body. Now, what will happen if, let's say, your arteries are too narrow because you have plaque deposits, you have a severe atherosclerosis, you're a smoker, you're diabetic, you're obese. Okay, so you have narrowing of your arteries. So what happens to perfusion? It decreases. So I rest my case. What about in blood volume? So if I lose blood or if I'm dehydrated, for instance, what happens to perfusion? Is there enough pressure to deliver blood and oxygen to all parts of my body? No. And then finally, if the pump fails, it cannot pump effectively. What happens to perfusion? Okay, so therefore, there are 3 elements that make perfusion possible. Since problems with perfusion can occur when one or more of these 3 elements fail, then can we also manipulate the same 3 elements in order to improve perfusion? Meaning, can you give medications in order to strengthen the contractility of the heart? Can we give medications that will increase or decrease blood volume? Yes. Can we give medications that will dilate or narrow arteries? Yes. So we can use the same 3 elements of perfusion because one or more of them can lead to a perfusion problem. We can also manipulate one or more of them in order to improve perfusion. You follow? All right. Remember when we discussed the renin-angiotensin aldosterone system last week? Do you also remember when we discussed sympathetic nervous system activation? Okay. So when a patient is in heart failure, let's talk about acute first. So right now, the patient's heart is failing. They're hospitalized because their symptoms are they can't breathe. Okay? They're gasping for air. What is the cause of that symptom? Why are they having problems breathing? Is there enough oxygen going around? No, because the pump is not pumping effectively. So less delivery of oxygen to the tissues automatically increases heart rate and respiratory rate, correct? Okay. Let's review what were the 5 triggers I mentioned last week that will trigger sympathetic nervous system activation as well as renin, angiotensin, aldosterone system. What were those 5 triggers? Low BP, low blood volume, low sodium, low oxygen, and low glucose. Okay. And I said, do all 5 have to be present? Just takes one, correct? So in acute heart failure, in acute decompensated heart failure, which one of the 5 is present when the pump is not effectively pumping? Blood pressure drops, correct? All right. So therefore, when blood pressure drops because the heart cannot pump effectively, what will automatically be triggered?
Heart rate will go up.
Sympathetic and renin, angiotensin, aldosterone system will be activated, correct? All right, so let's recall the effects of sympathetic nervous system and renin, angiotensin, aldosterone system. Let's refer to blood volume as, you remember the terms preload and afterload with Dr. Farrington? What is preload again? What is it? Volume, very good. So preload refers really to the blood volume, meaning this is the resistance that the heart must overcome in order to pump blood out of the ventricles, right? And through the aorta. So that's preload. What is afterload? The resistance that the heart must meet in order to pump it out of the arteries, okay, out of the blood vessels. So therefore, blood vessels refer to afterload, blood volume refers to preload. So in the case of heart failure, what do you want the preload to be? High or low? Why do we want it to be low? Because the more preload or the higher the blood volume, the blank the workload of the heart. The higher the workload, right? Which one is easier to pump? 5 liters or 4? 4 is easier, right? What about 3? Even easier. You get what I'm trying to say? Okay. So therefore, we want to decrease preload, correct? Let's go to afterload. Which blood vessel size is easier to pump through? Something this big or this small? This is easier, correct? So therefore, what do we want to do to the afterload? Do you want to dilate the blood vessels or constrict the blood vessels?
Dilate.
We want to dilate them to decrease afterload, decrease workload. All right, let's go back to the sympathetic nervous system and renin-angiotensin system, because you said that it will automatically be activated, correct?
Yes.
So once the patient's heart is in failure, let's look at again an acute scenario, acute decompensated heart failure. The blood pressure drops, correct? Renin, angiotensin, and sympathetic nervous system, are they activated automatically?
Yes.
Yes, without asking for permission. It will release aldosterone. It will cause epinephrine release, causing increased heart rate. And what will aldosterone do? Reabsorb sodium and water. So what happens to afterload and preload when sympathetic and the renin-angiotensin system are activated? Both rise, correct? Preload increases, afterload increases. Now, how the hell does that help a patient with heart failure? Does it help if the patient is in acute heart failure? They do not. You see how the body is very ineffective? Okay, so therefore, do we want the sympathetic nervous system and the renin-angiotensin system to be activated?
No.
Not in this particular instance, because the patient has heart failure. So therefore, in order for these patients to live a relatively normal life, what medications do we have to put them on forever? Beta blockers and ACE inhibitors. Okay, ACEI inhibitors to inhibit both the renin-angiotensin and the sympathetic nervous systems. You get it now?
Yes.
Okay, so we're kind of going fast forward there. So let's look at because that's what it explains here I'm on page 795 under pathophysiology. So long story short, that's the explanation of that paragraph, right? So because these autonomic nervous system responses are built in automatically once blood pressure drops, which is the case in acute heart failure, correct? So therefore, it doesn't help. It worsens the patient's condition, correct? So now the mainstay medications that these patients have to be on are beta blockers, ACE inhibitors. Are those enough though?
No.
How else can we decrease preload? Diuretics will be mainstay as well. So you'll always see patients with heart failure on what medications? Diuretics, beta blockers, and ACE inhibitors. Or it could also be angiotensin receptor blockers, okay? ARBs or ACE inhibitors. What did we say again last week? What was the only hormonal response in fluid overload? BNP. Very good. So therefore, what will rise automatically here when the patient is in heart failure? BNP. So we use it as a diagnostic marker. So we draw, a patient comes in, clutching their chest, can't breathe. Okay, they have swollen legs, for instance. Okay, you listen to the lungs, very wet. Okay, very loud crackles. You draw BNP. What will the BNP show? Elevation. What released BNP again? The overstretched ventricles, right? So again, if you remember, what does Starling's law of the heart say again? Dr. Farrington talked about Starling's law. Who is Dr. Starling? Who is that guy? Some
I don't remember that.
some nerd, right? Okay, so Starling's law of the heart says that the more you stretch the heart, the greater the resulting contraction, correct? Yeah, so just like a rubber band. Okay, so you stretch a rubber band, how far will it go when you let it go? Really far, right? If you only stretch it this much, just drop there, right? So same thing with underwear, same thing. So underwear that's new, okay, very, tight garter, snaps, right? Really loose. No, 2 years later, same underwear. No more stretching, right? It'll just fall down. No resistance. Okay. So therefore, that's what it says here. So if the heart chambers, the ventricles become overextended, will it still snap like your brand new underwear? No more, because they were overstretched already. Okay, because there's prolonged stretching for how many years, how many decades already. That, just like the underwear, just like the garter on your underwear, it will weaken. All right. So here's the explanation. I'm looking at figure 25-1. So this is the trade-off. We have a bigger space, but then we don't have projector. So figure 25-1 is the long story short of the effects of renin-angiotensin and the sympathetic nervous system. Any question on this figure? So do we want it to continue? In heart failure, no, right? We want to suppress it by what medications again? ACE inhibitors, beta blockers, and
ARBs. Lasix.
diuretics. Okay, very good. Let's look at clinical manifestations, page 796. There are 3 types of heart failure. We have left-sided, right-sided, and then we also have normal cardiac output heart failure. However, we'll only focus on left side and right-sided heart failure. So the easy way to remember this is using anatomy. Left-sided heart failure is also called congestive heart failure. When we say left side heart failure, we're referring to congestive heart failure, CHF. That's left side. Anatomy. Thank you, Miss Bailey. Let's look at the left side of the heart. What does the left side do? The left ventricle and the left atrium. What do they do? So they receive blood from where? From the pulmonary veins, right? Okay, so blood that went to the lungs via the pulmonary artery returned to the left side, right? Carrying oxygenated blood now. Okay. And where will the left atrium pass it to when it pumps? The left ventricle. So, and then the left ventricle pumps, where will that blood go now? To the aorta and all over the body. Imagine a scenario wherein that left side fails. It's not pumping effectively anymore. What could possibly go wrong and what manifestations will result? So there's congestion, correct? Congestion where? In the pulmonary circulation, so the lungs will sound wet. Okay, so that's responsible for the crackles that you hear because there's congestion in the lungs now. What about in the aorta? Because that blood is supposed to go out. So now both the left atrium and the left ventricle do not pump effectively. So there's congestion in the pulmonary circulation as a result because the left atrium isn't pumping well. What about the left ventricle? It's supposed to do what to that blood that enters it? It's supposed to circulate it through the body, right? It's supposed to pump it and give it to everybody, starting with the brain and then the lungs itself. Because remember, the lungs will perfuse via the bronchial arteries, right? And then give blood to the lungs and then so on to the kidneys, to the GI tract, everybody. So therefore, what will be the other set of manifestations? So you say pulmonary congestion, so that would be pulmonary edema, crackles, shortness of breath. So that's the pulmonary congestion side. What about what happens to cardiac output? Decreases. So what are manifestations of low cardiac output? Hypotension, what else? What happens to urine output? Decreases. What happens to coronary perfusion? Decreases. There will be ischemia, chest pain. What about the GI tract? Will the GI tract receive blood? What happens to peristalsis? What happens to, will there be nausea, vomiting? Yes. Will there be good circulation to my feet? So those are all manifestations of low cardiac output. Okay, so two sets of problems in left side heart failure: pulmonary congestion and low cardiac output. Let's go to any questions on the left side? Let's go to the right. So therefore, if you examine the manifestations in left side heart failure, are they acute or chronic? They're all acute. Okay, there's no such thing as chronic manifestations of left side heart failure. Because can you sustain prolonged, can you live with left side heart failure like forever? No, those are all acute symptoms. Okay, you can't live outside the hospital with acute left side heart failure symptoms. You have to stay in the hospital. Let's go to the right side. What is the job of the right side? Where did that blood come from?
The body.
From the upper and lower parts of my body. So if the right atrium fails, as well as the right ventricle fails, what will be the manifestations? If there's congestion everywhere, let's start with the head. You have a headache, right? Yeah, because there's increased intracranial pressure. What happens to your neck veins? What happens to, so that's above. So will there be congestion here in my upper extremities as well? What will happen to my liver? It will enlarge. What happens to my abdomen? Okay, distended ascites. What will happen to my lower extremities? Peripheral edema. All right, so are they acute or chronic?
if you don't treat it.
Most of them are chronic manifestations, okay? Because did the peripheral edema occur in a matter of hours?
No, it takes time.
It took days, right? Took 4 days to a week in order to form peripheral edema. You just don't wake up one day, oh, they were fine yesterday. Whoop. What is this now? So it took several days for that fluid to form in the periphery. So therefore, how long will it also take to go down? It will also take a while. Unless you, of course, the patient is in acute heart failure, and then because when we say acute heart failure, does that mean they also have right side heart failure? Yes, right? Because if the left side fails, of course, the right side will also fail. So most people with acute heart failure, with congestive heart failure, will have both sets of manifestations. They'll have the right side as well as the left side. Okay. So when they come in, we'll give them lots of diuretics. We'll start with 80 milligrams twice a day. So that's a lot, right? And then we taper down 60 twice a day and then 40 twice a day. So that will drop the edema fast. So every day they'll lose anywhere but between 6 to 8 liters a day. Okay, so that's how fast the IV diuretics will drop the preload. Okay, but can you do that at home? No way. Okay, you need IV diuretics in order to drop the fluids out. Then you have a summary chart 25-1, page 796. So you have there the manifestations we just talked about. So congestion manifestations and low cardiac output. All right. Any questions? So if I put it on select all that apply or a drag and drop, let's say I have categorization. So these are the next gen type questions. So I'll put the manifestations all on the choices, and then the instructions is drag the manifestations, whether they belong to right side or left side heart failure. Okay, so you drag them. All right. So that's categorization on Canvas.
This one, 225.
-1, yeah. Okay, on the paragraphs though, there's the explanation, and which I hope I explained. Let's talk about a few which I did not. So you know about dyspnea on exertion, right? Because of low cardiac output, patient will have dyspnea. What about paroxysmal nocturnal dyspnea? What does this mean?
You wake up in the middle of the night.
Correct. What causes this? Why does the patient with heart failure have PND? Okay, that's correct. So during the day, the patient has low cardiac output, correct? Because your metabolic needs are higher during the day, correct? At night, metabolic rate drops. So the body's oxygen demand also drops. So even if the patient's heart is in failure, at night, it compensates because there is less demand for oxygen. So therefore, all of a sudden, all that fluid that was outside during the day, because of edema, seeps back into the vascular compartment at night. So now, all of a sudden, there's increased blood flow to the kidneys. So of course, what will the kidneys do? Okay, and then since all the fluid again returns to the vascular compartment, so does it in effect drown the patient all of a sudden at night? So that's responsible for the paroxysmal. What does paroxysmal mean? Sudden onset and sudden cessation as well. Okay, so that's what we call like come and go. Okay, suddenly comes, suddenly stops. Okay, paroxysmal. And nocturnal means at night, and dyspnea, of course, is difficulty breathing. Okay. The next paragraph talking about cough. So hacking cough, or especially if the sputum is frothy, that's a manifestation of pulmonary edema. Fluid in the lungs. When the patient coughs, sometimes it's pink tinge as well. Okay, so it looks pink, frothy. So that's sign of pulmonary edema. Okay. Why does the skin feel cool and clammy?
Or tissue perforation.
And that's also the effect of renin-angiotensin aldosterone system and sympathetic nervous system. Okay, so that's basically vasoconstriction. So when we have vasoconstriction, where does the blood go again? Blood is shunted where? To the central organs only, heart, lungs, and the brain. So does the skin get any blood flow? What will it feel then? Cold and clammy. And then we already, the right side is self-explanatory, right? We already talked about the paragraphs. Okay. Let's now go to the treatment. Pulmonary edema, the explanation is there. Again, what's the main cause of the pulmonary edema? Is it increased capillary permeability or is it hydrostatic pressure? This is hydrostatic pressure. Okay, so congestion in the pulmonary arteries and veins. So they will push water out and there's only one place it will go, which is in the alveoli. What diagnostic tests again do we use to diagnose heart failure? BNP. And will an X-ray help? Yes, X-ray will show pulmonary edema. Okay, ejection fraction. There are two types of echocardiograms. We're on assessment and diagnostic findings. Third paragraph under ejection fraction. To measure ejection fraction as defined is a measure of ventricular contractility. So it's the percentage of end diastolic blood volume that is ejected with each heartbeat. So we need an ultrasound to measure this. So that ultrasound is called an echocardiogram. So it's basically an ultrasound instrument. So there are two ways to do echo. So we can do two-dimensional or also called transthoracic, meaning the probe will be rubbed over your chest wall. Okay, so you lay down on your left side and the technician will run the probe, put some jelly and then run the probe up and down to look at using ultrasound waves, sound waves to look at to bounce it back against your heart structures and you will create a picture. You'll measure the heart size and the size of each chamber, and then more importantly, how much is being ejected by each chamber. So normal ejection fraction is between 55 to 65%. Again, normal ejection fraction is between 55 to 65%. So for instance, if your ventricles receive 70 ml of blood, for instance, 70 ml enters it, how much will come out? Which is how many ml? Around 40 to 50 ml will come out. Does that make sense? So the heart, therefore, does it completely empty with each contraction? No, some are left behind because the normal ejection fraction is only between 55 and 65. So in patients with heart failure, what do you think will be the ejection fraction? Less, it will decrease. So let's say it's 35, only 35% or 25. Okay, so is that pretty bad? It's very bad. So when we get to the classification, which is the next one, okay, so look at table 25-1. NYHA is the world standard for classifying heart failure. So we have here class 1, 2, 3, and 4. So how is this asked on an exam? I'll give you an example of an actual NCLEX exam, which a graduate shared with us in the past. You're not supposed to do this, by the way, because you sign a document when you take the NCLEX that I will not talk about the exam afterwards, okay? And then you sign it under perjury. But of course, where's the NCLEX police? Anyway, so you didn't hear it from me. The two classes that you really need to remember is class 2 and 3, because look at class 1 and class 4. Let's start with class 1. If you have class 1 heart failure, do you have any symptoms? No limitation of physical activity. Ordinary activity does not cause undue fatigue, palpitation, or dyspnea, meaning When I take a shower or run to the mailbox or go to the bathroom, do I have any symptoms? No, because they are ordinary physical activity. If I have sexual intercourse, will it cause symptoms? No, because is sexual activity ordinary activity? Yes, that's ordinary activity. Unless unless you're really like have like really aggressive, But that's not normal physical activity anymore, right? So therefore, is it easy to remember class one?
Yeah.
Yes, they have a diagnosis of heart failure based on, let's say, ejection fraction. It's less than 55%. So they have heart failure, and then they have a diagnosis of maybe they had a heart attack or whatever is the other causes. They have atherosclerosis, right? They have high cholesterol, whatever is the cause of their heart failure. So they have that, but they're class one because do they have symptoms? Not with ordinary physical activity. We see symptoms, so let's say they run a marathon. Now they get really symptomatic, okay? Because that's not ordinary activity anymore. You follow? All right. Let's go to class four. Look at class four. What does this patient look like? Do you see this patient out here in the community? You see them in school, you see them, working or going to the park. These are bedbound patients. These are homebound patients. Because look at that. Unable to carry out any physical activity without discomfort. Meaning, if they're resting, are they symptomatic?
Yeah.
You can bet yes. They're just laying there. They're just laying down. They're already symptomatic. See, symptoms of cardiac insufficiency at rest. So they have shortness of breath even when they're laying down or sitting down. Okay, no matter what they do, they have symptoms. If any physical activity is undertaken, discomfort is increased. So do you see these people out and about? You won't see them. Where will be the likelihood that you'll see these patients? At home, a nursing home, or in hospice. Okay, so these are pre-departure people, right? So they either need immediate heart transplant or they're under hospice. They don't have much left. So since 1 and 4 is easy to remember, 1, no symptoms, 4, like all the symptoms at rest, that leaves us with class 2 and 3. Class 2, what's the difference between 2 and 3? Slight limitation of physical activity, comfortable at rest, but ordinary physical activity causes symptoms. So what are ordinary physical activities? Walking, going to the bathroom, laundry, shower. Okay, so those are ordinary physical activity. But can they do it? Yes, they can. They just have symptoms. They get short of breath, right? So they need to rest in between, right? So that's class 2. Let's look at class 3. Marked limitation of physical activity. Still comfortable at rest, but less than ordinary physical activity now causes symptoms. So give me examples of less than ordinary. Going to the bathroom or just getting up and picking up something, right? So that is now less than ordinary physical activity. They have symptoms already. You see the difference? Okay, so the actual exam question somebody shared was, it was a pregnant woman. Patient came in with 36 weeks age of gestation. You're doing maternity now, right? Yeah. So 37 weeks. Who are moms here? Is 37 weeks term? Yes, that baby can live, right? If you have, so you're due, right? Because 38 weeks is the desired, right? But 37, that's a viable child. So patient came in 36 weeks of gestation and they have class 2. That pregnant woman has class 2 heart failure. Question was, what will the nurse anticipate during this visit? What will the nurse anticipate preparing for this visit? A, stat C-section. B, schedule a future C-section. C, continue with Lamaze classes. D, nothing. Patient is 37 weeks of gestation. Patient has class 2 heart failure. What will the nurse anticipate preparing during this visit? A, stat C-section. B, scheduling a future C-section. C, what did I say C was?
Lamar's class.
Lama's classes. D, nothing.
Schedule B.
The answer will be B.
Yes.
Okay, why B?
She's not terrible yet because she's still like, it's on exertion that she feels
Right.
comfortable, but she's.
Right, so when do we expect her to go into labor? Pretty soon, right? Pretty soon, probably on the next week. So therefore, do we need to really do it now?
Because it's
No. We can do it maybe next week or in 2 weeks. All right, why? Is labor ordinary physical activity? No, I don't think I can do labor. Look at this patient. Comfortable at rest, but ordinary physical activity causes symptoms. Is labor ordinary? So definitely, can this patient sustain labor? They cannot go into labor. They will die if they go into labor. You understand? Because here, look at this. Patient has symptoms when they have ordinary physical activity. How much more if they go into labor? You understand? So that's an example of how you approach class 1, class 2, class 3, class 4. So if you have these patients, what activity will you realistically expect of them? Let's say class 3. You tell them, okay, you're at risk for blood clot. You're laying down there. Go walk around the hallway. Will you do that for class 3? No. Okay, class 3, look at class 3. Less than ordinary physical activity causes symptoms already. How much more ordinary, right? Okay, so this is how you use class 1, 2, and 3, and 4. All right. So again, which ones will you focus on? 2 and 3. 1 and 4 is basically easy, right? 1, you're fine. Class 4, they're dying. Okay, so you'll see this on the notes if you have that habit already of reading progress notes on Epic. So to look up your patient. So they'll mention this one a lot. HFrEF. So if you wonder, what does that stand for? That's heart failure with reduced ejection fraction. Then you always look at the percentage. Well, how bad is it? So you can see, is it less than 40%? Is it 50%? All right. So that's what HFrEF means. We can skip table 25-2 because we focus on NYHA, which is 25-1, correct? All right. But if you look at that table, it really is similar to NYHA because again, the NYHA is the gold standard. So pretty much all other criteria will follow NYHA. Medical management now. So we already discussed diuretics, beta blockers, and ACE inhibitors or ARBs. Here are the complete medications. So the textbook categorizes them according to their function. So under pharmacologic therapy, page 799, so it begins with the enumeration. So for instance, it talks about the diuretic, angiotensin system blocker, beta blocker. Now let's go to the table 25-3. So diuretics, we have several types of diuretics in that table. Look at the therapeutic effects. Again, lowers preload, right? And then look at your nursing responsibilities. So these are now the testable part of any drug chart. So whenever I have drugs on the exam blueprint, these are what you expect to be tested on whenever there's a drug. I will always ask you about the nursing considerations. What do you need to know as the nurse? Because who's giving these drugs? So if something goes wrong, who's responsible? Right, so who will share the jail cell with you? You and the doctor. However, it's most likely just you because doctors have a higher coverage for Yeah, insurance, liability insurance, you just have the minimum. You only pay 120, like I pay 120. Those guys pay tens of thousands of dollars for the premium. Okay, because they have, higher chance of lawsuits. But so they'll always go after who has the insurance. Okay, then who is likely to, lose? Go to the RN. Oh, Ramata. I'll go after Ramata. So you need to know your responsibilities. Okay, so before, during, and then after administration of the drug. So let's start with diuretics. What do you do before? Very good. So if the potassium level, knowing that furosemide drops potassium, okay, so look at it, right? So what do you do if the potassium's already below normal or right at the minimum? Can you hold it? Is that under your scope of practice?
Let the doctor know.
Hold and then notify the provider. Are we clear? So it's not just hold, okay? It's hold and notify because you need an order to hold it, right? And don't take it for granted. Like I sometimes forget. I just hold, and then although I send a chat because it's easy now on Epic, you don't have to call because that's really a hassle when you have to call the doctor. Now you can chat with the doctor. So there's a under the upper left, so there's an option there to text. So when you text, it's recorded, okay, that you sent a message. Whatever message you sent, okay, you notify a doctor potassium's 3.5. I'm supposed to give 40 milligrams of diuretic. I'm not comfortable giving this. Okay. Can I get an order to hold it, please? Whether they respond or not, you did your job. Okay. And then that will cover you. Right. It's because you put hold, but then you didn't order, you get an order for hold, but it's unsafe to give. Right. As a professional, I'm not giving that. Okay. But then you did your part wherein you notified. Okay, because if you go on the phone, you'll be on the phone all day because they have other priorities. Okay, your patient's not the only under that provider's care. They have other patients. Okay, so you can't blame them also for not taking your call, right? So EHRs recognize that. We have the text now. Okay, wonderful. So good for you, good for everybody, right? Because who wants phone calls here? Text is better, right? Yeah, just text and it's recorded, right? You send the text message. They can't erase that. Aldosterone antagonist, spironolactone, this thing will cause hyperkalemia. Okay. Then ACE inhibitors, okay, because how they work, because they suppress the angiotensin, renin-angiotensin aldosterone system. So therefore, will sodium be retained? No. Sodium will be no, you're giving an ACE inhibitor. So therefore it will suppress the RAS. So therefore no sodium. You will lose sodium, but you will retain potassium. So side effect is hyperkalemia. Okay. So therefore, what diet do you promote with the patient? Low sodium. Very good. No, sorry, it's low potassium. Okay. Of course, low sodium also because it's heart failure. And what's a problem with this drug? Side effect is cough. Okay. So ACE inhibitors have a nagging cough, and then ARBs is the option. So if the patient has nagging cough, you tell the doctor, and then they'll switch them to ARBs. Okay, because this one has the same hyperkalemia effect, but no cough. There's a combination drug now. So they put together an ACE inhibitor and an ARB together. They created Entresto. That's the brand name for sacubitril and valsartan. That's Entresto. So 2-in-1. So they, ran out of ideas. So they, how artists sometimes do that? They have no new songs. Let's do a greatest hits. Okay. So this is what they did. Let's combine some drugs. Okay. No new ideas. Okay. Let's combine it. There, sell it. And beta blockers. So observe for heart rate and blood pressure because both will drop. And then we have vasodilators here. We have ivabradine and hydralazine. Hydralazine is a commonly prescribed medication also. It's a good vasodilator. And digoxin. So digoxin obviously is an inotropic, so this one will improve cardiac contractility, but in doing so, it will do what to the heart rate? It will lower the heart rate. And most patients are on all of these, so therefore, what could go wrong when you patient is taking furosemide and digitalis at the same time? Toxicity. Remember last week? Did we talk about this last week, right? Okay, so it needs potassium, right? So it needs potassium to enter the cell. So if you're taking diuretics with this, so you're guaranteed hypokalemia, so higher risk for toxicity. And manifestations should be here. The next paragraphs, by the way, discuss how the drugs work. So I encourage you to read it if you need a refresher on your pharmacology. And you have a chart there specifically for monitoring patients who are taking diuretics, chart 25-2. Is this a good select all apply? Yes, I can say your patient is taking furosemide. The nurse will incorporate which of the following into the care plan. Select all that apply. So that's chart 25-2. For signs and symptoms of toxicity, because it's still in the market. However, in practice, when you work in, except med-surg, in med-surg, if you work med-surg, you'll see digoxin. However, when you go to telemetry ICU, you will not see digoxin on those units because if the patient is on digoxin, we don't give it when the patient is in acute heart failure. It's not good because it's hard to control because we're giving so much diuretics when the patient comes in, acute heart failure. And I mean, I work in telemetry, so I'm next to ICU. So ICU telemetry, all our patients are critical. So we give lots of diuretics, so we don't give digoxin. Okay, so when they go back, when they're stable, they go back to med-surg. Then if they're on digoxin, they'll resume it. However, more and more doctors, especially younger doctors now, do not prescribe digoxin anymore. So digoxin is like becoming a relic now. Okay, but it's still in our textbook, so we still test it. Okay, but just be FYI, not too many patients are taking digoxin anymore because the evidence is showing, no, what's the point, of giving digoxin? Okay, because it's causing lots of dysrhythmias. We'll talk about the dysrhythmias that it causes under module 8, okay, later in the semester. So we'll skip the IV medications because these are now dopamine, milrinone, which is milrinone is what's the brand name? It's Midodrine. Okay. But anyway, those are IV medications, so we'll skip the IVs. Okay, so no dopamine, no milrinone, and the vasodilators. Don't worry, we'll get the vasodilators that you will be giving under module 8, okay, under dysrhythmias.
So for now, we just know, ones in the other table.
Yeah, except the IVs. For manifestations of digoxin toxicity, it's on page 802 under digitalis, second paragraph. Paragraph that says, a key concern associated with digoxin therapy, see that, is digoxin toxicity. And manifestations are anorexia, nausea, vomiting, visual disturbances. When we say visual disturbances, that's blurring vision or double vision, okay? Confusion, bradycardia. All right, any questions? Okay, let's go to nutritional therapy. So for nutritional therapy, this is referring to sodium. There are different levels of sodium restriction, and I discussed this last week, right? And what did we say about salt substitutes again?
They increase the potassium.
Okay, they're made of potassium, especially the cheap ones. So for sodium restriction, the standard is 2 grams per day. How much is 2 grams? Who's your dealer? It's not much, right? Yeah, 2 grams is, and that's just per day. So if you spread it out for 3 meals, that's not much sodium at all. Okay, so what will your food taste like? You like to eat? I want chicharron. Okay, I want the hot sauce. Okay, there's not much, well, you enjoy life, right, with food. And then so you can see why these patients get readmitted, right? Because will they likely comply with the sodium restriction? No way. I'm the number one. I'm not going to. There's a party. No, it's my birthday. Of course, I'm going to eat, Taco Tuesday. So what are the foods that are naturally high in sodium? Milk. What else? Soda. Cheese. Yeah, anything canned, right? Except frozen you can get. Yeah, frozen vegetables are okay, but canned are, yeah, they have high sodium. Okay. As far as oxygen, we'll discuss oxygen therapy another time. Some patients, the risk factors for heart failure include obstructive sleep apnea. People with OSA? No. Risk factors usually, obese patients and those who have a short neck, a large uvula, uvula, the thing at the back of your throat. So those are common causes of obstructive sleep apnea. So if that's the cause of a patient's heart failure, it should be treated, and then we use CPAP for them. Don't be surprised also that patients with heart failure, even if they don't have obstructive sleep apnea, will be put on BiPAP. Okay? The benefit of BiPAP is it actually helps decrease preload. Okay, because how does BiPAP work, or CPAP? It blows air, right, into your airway. So therefore, what happens to your intrathoracic pressure? It actually increases. Okay? Because if you're blowing air even at the end of exhalation, because at the end of the exhalation, when I exhale like this, the pressure goes to 0. If you put the patient on a BiPAP or a CPAP, does the pressure go to 0? No, it will stay. The lungs will stay partially inflated. So therefore, the heart shares the same space as the lungs, right? So you have your heart here and then right lung, left lung. So when they inhale, what are they doing to my heart? Squeezing it. So what happens to blood return when at the peak of my inhalation? Drops. What happens to cardiac output at the peak of inhalation? Or decreases. However, it's only for a second, right? When I go, but it didn't take 1 second, right? So it and then my lungs relax, I exhale and then the heart recovers. However, if you put them on a BiPAP, does the heart fully re-expand? No, because the lungs stay hyperinflated. So therefore, what happens to venous return? Decreases. So what happens to preload? Decreases. Does it help heart failure? Yes. So that's how BiPAP helps. Okay, so you wonder, oh, this patient doesn't have sleep apnea, but then they have heart failure. Okay, so COPD patients, heart failure patients are placed on BiPAP. It's a non-pharmacologic way to drop preload. Plus, it helps oxygenation also, okay, especially if they have, say, pulmonary edema, so it helps as well. We'll skip the procedural and surgical interventions. Okay, so the CRTs, the biventricular valve and then the intra-aortic balloon pump, so we'll skip all that. Let's go now to discharging this patient. I'm on page 806. So I'll give you an acronym to remember all these. It will include exercise or activity, and then the diet, and then medications. Okay, the acronym is MAWDS, MAWDS. MAWDS. It's not in your textbook. This is just to help you with your notes. So when you discharge somebody, you educate them on MAWDS. So M is for medications. What are those medications again? Table what? Table 25-1. Okay, so those medications. All right, that's M. A is activity. Activity is under page 806 here, promoting activity tolerance. So it explains there how much the activity that we promote is walking. Used to be swimming, but then what if there's a danger, because what if they drown? Yeah, because they have activity intolerance in the middle, and then they're in the deep end. Now too late. So walking is safer. So they tells you here there's activity, there's a chart, 25-3. Nice apple there. An exercise program for patients with heart failure. So that's A. W is for weight. And you know this, right? So how much weight is reportable?
Less than.
Okay, so we have here, let me find it. Okay, page 810. Under chart 25-6, it's now in the bottom, but since we're doing weight, so what is reportable? So on chart 25 dash, did you see it? 25-6? Okay. Correct. So you report if they gain 2 to 3 pounds overnight or one day, or 5 pounds in 1 week. Are we clear?
Yes.
So that's the weight. And of course, to weigh the same time each day, right? Same clothing, same scale. D is the diet, and we just concluded the low sodium diet. And then S would be the signs and symptoms. What signs and symptoms are reportable? Do you report, we know about the weight. Do you report acute or chronic conditions? Acute. So I guess you can summarize it on chart 25-6, although 25-6 doesn't really give details on the medications, but the medications teaching are on table 25-1. So 25-6 should contain the mods pretty much, right? So there's medication there. Although activity was a separate chart. And there's the weight is there. Diet was discussed in another paragraph. Okay, so signs and symptoms. On the same bullet, report immediately the following is this on top of the weight gain, we also have unusual shortness of breath, which is this acute or chronic? Obviously acute, right? And what about increased swelling of the ankles? That's also acute, okay? Because they'll have usual swelling, but then if there's an unusual or increased swelling, then that's acute. Persistent cough, that's acute. Loss of appetite, that means this is nausea, vomiting already, correct? Anorexia, which are signs of decreased cardiac output. And development of restless sleep, meaning when they have restless sleep, that means are they waking up during the night? Does that mean they're having more paroxysmal nocturnal dyspnea episodes? And profound fatigue, again, that's a symptom of decreased cardiac output. So is the orthopnea. What's the difference between dyspnea and orthopnea?
Is when it's positional.
When you cannot breathe laying flat. Okay, that's orthopnea. So this part here where it says increase in number of pillows needed to sleep, that's orthopnea. All right, that concludes heart failure. Take a break. Come back at 3 o'clock.